Good afternoon, and thank you for those presentations. I really enjoyed them. My name is Fahey. I've had the pleasure of serving as Vice President of your organization for the last 12 months. So it's my pleasure to introduce our President, Dr. Tom Fahey. And I will say that one of the highlights when I was nominated Vice President last year was I was looking forward to this. Tom. Also because I've known Tom for almost 3 decades. He was one of my first attendings in Dallas, and I have some very, very good stories that we could share later on about him. So I have no disclosures except that most of the material you find here were approved by Stacy, Tom's wife, and the veracity of that's been confirmed. So I'll just give you, my job is to describe to you who your president is and what he's like. And you all know Tom as Chief of Endocrine Surgery at Cornell. He's also been the program director of the general surgery program there for, I believe, Tom, 50 years? You can see all the accomplishments he's had. His clinical and research interests and contributions to endocrine surgery are unparalleled, in my opinion. He has written many book chapters and served in a variety of academic societies and on boards. He was born in New York, and after his training, graduating from Duke and Cornell, went to Australia to do a fellowship in endocrine head and neck surgery. And I had the privilege of going to that same hospital later on, and they said they never wanted any more Americans since Tom left. I don't know what happened. He joined us at UT Southwestern shortly after that as a young faculty member trying to build an endocrine surgery practice, and then shortly came back home to Cornell, where he has been and has risen to the professor level. He's consistently been recognized as one of the best doctors in New York, and given how many doctors in New York here, I wanted to confirm some of that. But he's been cited by New York's best doctors by the New York magazine for many years, and it's a testament to his clinical excellence in that community. So really, who is Tom Fahey? This is the part that I had to go and Google to figure out exactly whether these things are accurate or not, Tom. This is a page from the website where you can see they proudly show that he's one of America's top doctors and one of the New York top doctors. So I decided I'd reach out to some of my fellow colleagues who are in the New York area. And this is
Tom, how's it going?
James.
Yeah, I know the New York magazine Best Doctors list. You want me to vote for you. I don't know how I feel about that, Tom. You'll do all of my normal calcemic hyperpara patients for the next year? Sold.
So clearly there's some stuff going on behind the scenes we're not aware of. And I figure this may have just been a New York problem, so I reached out to another endocrine colleague who's in Birmingham, who has no vote.
Yes, I'm on the nominating committee for the AES. You want me to nominate you for president. Is that what you just said? Well, normally there's a defined process, but you're going to give me free tickets to Hamilton if I do that, okay? Well, yeah, I guess I'm happy to, but you'll have to convince Alan Sipperstein, and I'm not sure he's such a Broadway fan. Oh, you're going to make sure that he gets to host the meeting in Cleveland? Really? Okay.
So, I looked up Tom's quote-unquote research productivity. He sent me an email the other day saying he had 53 papers in the last year, so I decided to go look them up, and I couldn't find anything, Tom. I mean, I saw this research on plants and trees, so I'm not so sure about that. We'll have to call your medical advisory committee to do that. But most seriously, Tom is a real innovator. In my experience with him, he has never seen an idea that he couldn't find some wisdom. And every time I've called him about an idea, no matter how harebrained it is, he's always supported me and been willing to try it out for the benefit of the patient. This is his website, RFA for Life. I see you've gotten into the RFA business. But I think you do it with such grace and care for the patients that we take care of. The plaque, we invited Tom as a ground round speaker not too long ago, and he talked about some of the molecular profiling that he's been doing for many, many years. Tom is also a strong mentor. I've reached out to several of his prior trainees, and I'm not sure who spells things at Cornell, but apparently this is the door to Tom's office. So I'm not sure what kind of endosine surgery you guys practice there, but given the story with the New York top doctors, I don't know anymore. And then, Tom's a great mentor. He's trained a lot of people, and he certainly was one of my, I was a fourth-year resident out of the lab, and he came and taught me a lot of lessons. And so I thought I'd just share, this is one of my favorite lessons that Tom taught me. It's called the ABCs of endocrine surgery. And basically, they stand for accuse, blame, criticize. And if that doesn't work, you deflect. So whenever we had a bleeding patient, there was always somebody else's problem, not ours. And this is Tom the sportsman. Some of you may recall this AES meeting at Duke where we had the privilege of playing in the basketball arena. And one thing I noticed, Tom, was you were nowhere near the ball at any point. I couldn't find a picture where you actually had the basketball in your hand. So I worry about your sports skills. So what will retirement look like for Tom? Apparently it'll involve beer, sombreros, and glass blowing. So there's your president doing a glass blowing thing a couple of days ago. And there was a winner. I'm not sure who it was, but maybe you'll share that with us when you give your address here. Tom's family is here, so I would be remiss to not share the fact that he's also a very strong family man with a tightly knit family. And so I guess when he first started, he was looking for love on the streets of New York, and he took his bicycle and went out looking for someone. And then he met Stacy, his wife. But Stacy, as you can tell from her crossed arms, didn't want any part of this. Apparently, Tom, being a persistent, relentless parathyroid surgeon, kept searching. He was clearly dejected. You can see him walking home from that encounter and head down and, not very good spirits. Almost, threw himself off a building the way that looks. And then he calls Stacy and says, look, I have a boat. If you want to come out, tries again. And it worked. And it worked and led to, I'm not sure if that's Mr. Trump or is that Tom Fahey. They were happily married. They met in college and happily married with three kids and 2 grandchildren. He's a twice grandfather now. He's very involved in family life, as you see here, likes the outdoors, as you'll find out here shortly. He says he's a surfer. We haven't yet seen live video, but there's a lot of pictures of him and on the water on a surfboard. And then the picture on the right is his first attempt at skiing. And I'll let him tell the story because he came to skiing late in the game and apparently did a lot of tumbling down the mountain, less skiing. I'm not sure if he's invited back, but I just opened an invitation for him to come back to Park City to go skiing. Maybe we can work on his skiing game. And then Stacy says when he needs to be at work, because when he's home, he just tears stuff down and neighbors complain. Thankfully here, I think you see that they pulled him away to go and complete his EPIC notes because apparently he doesn't complete his patient records on time. So you got to get him some work somehow to keep him off the grounds. But I wanted to put this seriously. These are quotes from his trainees, fellows, residents, and they're consistent across the board. There is not any, that you can tell who the man is from what people say about him. And this, I think, just encapsulates from 3 different fellows who he is and what he has meant to their careers and their lives. And I will say, I'll add mine there to say that he's been a real mentor to me. So I will stop there. I think, who is Tom Fahey? He's a curious surgeon scientist. He's strong father, a gentleman who treats everyone with respect and dignity. He's a gifted surgeon, grandfather, mentor, scientist, and friend. So please join me in welcoming your president, Dr. Tom Fahey.
Thank you, Fiemu. That's certainly a rousing introduction. I'll say, you know, the photo of me out chopping wood, that was probably right after having to take Fiemu through a thyroidectomy. It was either that or a psychiatrist. Thank you, everybody. It has truly been a privilege to be your president over the last year. I have been actually worrying about this talk for about a year. So, of course, you know, been getting ribbed by Alan, who told me, oh, he had his done a month ago because it was virtual. So I will like to embark on my story with the AAS and some thoughts about where we will go in the future. It starts there at Cornell. That's a picture. The back one was a picture of NYP and where I am back again. My first chair is there depicted in the top left corner. That's Dr. Tom Shires, who was a phenomenal surgeon and phenomenal chair of surgery. And then in the upper right, I was very fortunate early on, Tom Shires, and that's Tony Cerami, who was at the time the Dean of Rockefeller and the head of the Laboratory of Medical Biochemistry. And those two labs got together because Dr. Shires' interest was in shock, and Tony Cerami had purified cachectin at the time, which proved to be TNF. They were the same molecule, and Tony Cerami was the one who recognized that this was an intrinsic mediator of shock, and those two went on to have a great collaboration, which I was very fortunate to be a part of as a medical student, and then further again as a resident. And then the picture in the bottom, probably most of you know, is Dr. Murray Brennan, who was my inspiration really as to be an endocrine surgeon. I was first on his service as a medical student in 1984, where he actually did quite a bit of endocrine surgery at that time. By the time I rotated onto his service later in 1988 or 1990, he was doing much less endocrine surgery. But it was him who, when he called me up one day and said, Tom, I want you to come over and meet somebody. And in those days, it was a pager. When you got paged to Dr. Brennan's office, you're like, uh-oh. But he had in his office Professor Tom Reeve from Sydney, Australia, from the Royal North Shore, and he said, I think you should consider going there for your next step. And I did. This is a picture of the Royal North Shore. Really was actually a very kind of drab building. They have now built a new hospital, but its location was unparalleled. This is the north side that we're looking at. The south side had an unbelievable view of Sydney Harbor, which you can kind of just see there in the background up there. And really, rounding in the morning on patients on that south side was fabulous because you could just sit and take in the vista. This is a Tom Reeve here on the right over there, and then Lee Delbridge here on the left. And I only had the opportunity to operate with Professor Reeve a couple of times because he had kind of retired at that point or had just gone into private practice. And my mentor in Sydney was really Lee Delbridge, who I actually communicated with, to see if he was going to be here because he truly was who taught me how to operate as an efficient surgeon. And you can see, obviously, myself there and my wife in the background. You know, when we went to Australia, in those days, residents didn't make much money. I was making $20,000 a year at Cornell, and you know, somewhere in the middle of the flight to Australia, my wife asked me, "Are you getting paid for this?" And I said, "I think so, but we'll have to see when we get there." So we got there with literally 4 suitcases. These were our 2 little ones at the time, Caitlin and TJ. That was our car, a 1973 Datsun. Went on to become now the company's Nissan, with probably 150,000 miles. This was not an infrequent occurrence, trying to, you know, tinker to get the car to actually get me the 5 miles or so to the Royal North Shore. And it was a fairly common occurrence. While we were there, I was very fortunate to have our youngest, Erin. You know, she saw this picture and immediately said we were trying to abandon her to the kangaroos. And in looking at it myself, I have to say I don't think I would recommend that my grandkids sit in a stroller like that with a mama kangaroo right next to her. So Lee Delbridge had said some things that he actually loved the AAS. He was Professor Reeve and Lee were both friends with Norm Thompson, and the AAS meeting was something that he loved to come to. And he said, first, the AAS meeting is without question the best endocrine surgical meeting in the world. And this he actually was written in a kind of a throwaway journal many years ago. But secondly, it provides the opportunity to meet up with friends, including those who have influenced his career over the past few years. And I have to say, I agree obviously with both of those. I'd probably amend the first one to say it's the best meeting in the world, period, not just endocrine surgical meeting. And secondly, the people that influence our careers are both those who've preceded us and also those who are following us, and as you can see from the program today. And lastly but not least, the States just happens to be one of the greatest countries in the world to visit, and not just the major tourist centers. Obviously, Cleveland being a perfect example of that. So, where are we in the AAS? Just thought I'd talk about some of our considerations that we've had over the last year. We had as a vision to maintain that of our founders. And as far as clinical excellence, I think we've continued to attract and retain the highest quality surgeons into endocrine surgery. We've certainly remained at the forefront of clinical innovation, and I think that's evident both by what we've seen so far, but certainly in the panel tomorrow on clinical, the advances in novel clinical techniques, I think is going to keep us there. And we've also been a leading society in establishing practice, standards of practice for endocrine surgery for both endocrine surgeons, but also general surgeons, surgical oncologists, minimally invasive surgeons, otolaryngologists, and urologists. Our guidelines, excuse me, our guidelines, I think, have become the definitive references for thyroid disease in adults, primary hyperparathyroidism, and adrenal incidentalomas, which was done with ACE. But these 2 new guidelines coming out, which we'll hear about at the noon session on the lunch session on Tuesday, definitive management of surgical management of adrenal disease and the management of secondary and tertiary hyperparathyroidism, continue to push us as a leader in the clinical arena. In education, I think our accreditation committee and our fellowship committees have kept us keeping the highest standards for fellowships in endocrine surgery, and will continue to do that. We have provided the foundation for resident education in endocrine surgery for residents in general surgery and other disciplines, courses for ultrasound and RFA, which I think we're just seeing the leading edge of. And probably the pandemic has certainly pushed us into webinars for patients and physicians. In leadership, James Lee, the visiting professor program, that was really him who brought that to the fore this year, and I think it's a great program which will continue mentoring for both junior and senior endocrine surgeons by our leaders in the field, notables like Quan Du, Martha Zeiger, Janice Pasica, and many, many others that you see and hear today. And then the quality verification program, which I know that some of you have volunteered to be in, which ultimately I think will promote a standard in endocrine surgery for hospitals and in what we need to do in hospitals around the country to have efficient and quality endocrine surgery programs. In research, I think our research awards, you heard this morning, I think phenomenal reports, and I would hope over the years, and I will work towards expanding those. I think we have to do what we can to make those even more significant, and I think we can. Obviously, our meeting provides a robust forum for presenting research at the annual meeting, and the question is, can we do more? I think the AES has provided a great forum for really some groundbreaking and practice-changing work over the years. This is just some papers from when I was a resident and fellow, outstanding progress in management of all areas of endocrine surgery: thyroid cancer, hyperparathyroidism, the management of pancreatic disease in MEN1 patients, and pheochromocytomas and hyperparathyroidism in MEN2. Really outstanding papers that were all presented here at the AES meetings. My first foray into presentations here at this organization was when I was back in the United States from Australia. I landed a job, as you heard, at UT Southwestern, where I was very fortunate to be recruited. It really was a phenomenal place to be as a first job. And while I was there, partly because Lee Delbridge we were doing a project there looking at trying to differentiate by MRI, and that was old-fashioned MRIs, benign and malignant thyroid nodules. And my goal was to try to look for markers that we could identify just on needle biopsy to do this. And while I was there, this paper was published by a group at Southwestern. Jerry Shea was the senior author. This was published in Science, and looking at telomerase. It was the first report of telomerase being a marker for immortality. So I jumped on that as a potential marker for differentiating benign and malignant thyroid diseases. And actually, this paper and paper from Martha Zeiger's group at Hopkins were presented back to back at that meeting in 1996 or 97. I guess it was 97, and we had actually come to different conclusions because of inflammation. We found that the telomerase activity was probably not going to be a really good marker, and because we see thyroiditis so commonly, it didn't seem like it was ultimately going to be good. But it did allow me to meet Dr. Zeiger, and we were able to form a collaboration from there. And so I think the AES was certainly very instrumental in the initial part of my career and the founding part of my career in endocrine surgery. Actually, while we were working on that paper, John Daly recruited me back to New York. I have to mention the unfortunate passing of John Daly a little over a year ago. He was a great mentor, a great person, and for one of his most notable contributions to me was that I got to meet one of our future endocrine surgery fellows, Maureen Daly Moore, who's here in the audience, when she was about 5 years old at his first holiday party at his house in Pelham in New York. I wouldn't have gone back to New York if it wasn't for the fact that they built the new hospital. So the old hospital is there. That's where I was a resident. The new hospital here. So new, old. And if that hadn't happened, I never would have gone back there. The old hospital was really quite dilapidated in its state. So it was a great time to go back to New York. While shortly after I got back there, a company called Affymetrix came out with this gene chip. And one of the things I think that I think Martha had come to realize that analyzing single genes was probably not going to be adequate to differentiate benign and malignant thyroid disease. And this chip actually, they were able to put 10,000 genes on a glass slide and have fluorophores, and then you could get a readout of that, and you'll see, we ended up embarking on a study to look at follicular tumors. At that point in time, you have to remember it was a little different. Follicular thyroid tumors, the decision was, well, do you take out half and then you wait for the final pathology and then you go back and do a completion thyroidectomy, something that even as a young attending I really thought was unnecessary and wanted to try to get away from. So I figured if we could just differentiate these two things up front, you could just have one operation, take out the carcinomas and the adenomas with a hemithyroidectomy and the carcinomas with a total thyroidectomy. So we used the Affymetrix chip to do that. This is a dendrogram, and you'll recognize this from, similar to what Tom Giordano showed us this morning, but genes that were differentially expressed between the top here, adenomas, the bottom here, carcinomas. And this was one of the first demonstrations that you could do this in any kind of tumor at the time. You notice that at the top here there was two tumors that are listed as C5 and C9. Those ended up being minimally invasive carcinomas, and who knows, Tom might not even call them carcinomas at this point in this day and age. So the differentiation was really quite remarkable. This was published in Clinical Cancer Research, and obviously they thought enough of it that they put this figure on the cover of the journal. I think one of our proudest achievements certainly was this kind of groundbreaking research. We published and presented here at this meeting several other papers. Our very own Carrie Lubitz presenting the one on the right. Over the years after that, we went back and looked at a much larger series of tumors, differentiating papillary thyroid cancers from hyperplasia, and the differentiation was really very good. Unfortunately, I wasn't either smart enough or Cornell wasn't really savvy enough to recognize at that time that this was ultimately something that could be marketed. Despite me talking to them, we actually did submit a patent for this. But as you know, this was recognized by others to go on, and this formed the basis ultimately for the Afirma, initial Afirma, versions of the Afirma test. We did go back and look at this after that to look at markers for more aggressive thyroid cancers. And one of the ones that came out, in the large series that we did, one of the ones that came out was ICAM1, which we found to be upregulated in aggressive papillary thyroid cancers. And you can see here in the top left is, absent of brown staining is the follicular adenoma, virtually no ICAM1. And then the well-differentiated and then the poorly differentiated on the bottom left, where you see, virtually everything there is staining brown. This formed the basis, and I'm not going to go through the whole. This is, covering about 15 years of work in just a few slides. But basically, we collaborated with a scientist named Munsu Jin, who had just arrived to Cornell, and Irene Min, and developed a CAR-T treatment for ICAM1. This is an in vitro study showing that ICAM1 killed ICAM1 targeting CAR-T cells killed basically all of those cells that actually were expressing ICAM1. We pursued this in an in vivo model, and you can see on the bottom row there, the mice that received the CAR-T therapy went on and lived essentially normal lives until they were sacrificed, but lived months after the treatment, whereas mice who received either no therapy or the non-transduced T cells were expired within a month of receiving the xenotransplantation. This has now been translated into a clinical trial, which we had on hold for a while, but is now back up and running. So patients with anaplastic thyroid cancers and refractory to treatment poorly differentiated thyroid cancers are eligible. The top line shows an FDG PET, and this is a dotatate PET. The reason the dotatate is there is because the CAR T sequence has in it an SSTR2 receptor, so that we could actually track where the T cells went. And you can see that they do hone in on the tumor cells. The most important part of this portion of the trial is just to show that there's no toxicity, which I was actually quite concerned about, given that it was ICAM1 and its known importance in an inflammatory pathway. But we've now treated 3 patients without any evidence of significant toxicity, granted at the lowest dose. This was the lab back when Dr. Koitkin was a member of the lab. You can see him there. He's learning. I think he'd probably been there for 6 months and was just watching one of the medical students was showing him how to pipette for the first time. Dr. Koitkin was the Lufthansa designated fellow. He traveled to Europe 11 times in the 2 years that he was in the lab. So it was amazing that we were able to get any productivity out of him. So back to the AES, because I think the AES has been foundational in my research career, given my early interactions here. And the question is, can it do more to facilitate research? And if so, how? And I'm going to talk about a couple of papers that we've just recently either published or presented a couple of topics. And this is being driven by my junior partner, Dr. Finnerty. And this first one is about parathyroid carcinoma. And we had a patient with parathyroid carcinoma. And the question is, should they have received any additional adjuvant radiation therapy? So we looked at the National Cancer Database and found that it was not associated with overall survival, that it was utilized in about 14%. The 5-year overall survival was 85%, and it did seem to be associated with advanced disease. So you can see from these data that it was more likely to be given with more extensive disease. This chart just is shown to demonstrate that in the bottom half there, that actually whether it was given or not, whether XRT was given or not, was really did depend to some extent on where patients were being treated. And in community hospitals, these percentages represent the percentage of, let's go back one, percentage of those patients that got EBRT, not necessarily a percentage of patients that were for instance, in the community. So about a third of the patients in community setting got radiation therapy, whereas only less than a fifth of the patients in academic and research settings got radiation therapy. So there was some variation in that. But the important part is that 11% of completely resected patients ended up getting external beam radiation. And many patients who had advanced disease did not get radiation therapy. And so really, there's really no, even though it was not associated with an improvement in survival, there was no real designation as to who should get it and who shouldn't. So one rare disease to one that's even rarer, and that's struma ovarii and malignant struma ovarii. And as you all know, this is a disease where you have thyroid cancer develop in an ovarian teratoma that has thyroid tissue in it. It's rare, but something that is a very interesting disease, and when we see it, raises a lot of questions. Do you do a thyroidectomy? Don't you? Should you give chemotherapy? Should you give hormone therapy, radiation therapy, or radioactive iodine? All of these questions that really are not adequately answered. And in fact, in the literature, you have papers that are, come to completely different conclusions. One that says that they should, all patients with malignant struma ovarii should have a total thyroidectomy and radioactive iodine, and another that says malignant struma ovarii is overtreated, this by our very own Julianne Sosa and Sanziano Roman, that it's overtreated and reserved radioactive iodine for extra-ovarian extent or distant metastases. So we again went and looked at the NCDB. Julianne's and Sanzi's paper was from an analysis of the SEER database. And over the course of just 12 years, just 158 patients, and 19 of them had been treated with radioactive iodine. And so the original hypothesis, was, radioactive iodine is probably associated with better survival, as it is in more advanced thyroid cancers. So the patients that did receive radioactive iodine were associated, more likely to have had distant metastasis, surgery at other sites, hormonal therapy, and lymph node positivity. But it was not associated with an improved overall survival. The important thing, because in many ways I didn't expect that was going to be the case, but the important thing is, once again, as in with parathyroid carcinoma, there's really no kind of stratification as to who got it or not. A third of the high-risk patients in both the NCDB and the SEER databases received radioactive iodine, and some that were in low or intermediate risk, who, if this was a thyroid cancer, we would not recommend radioactive iodine, did receive it. So the question is, in that setting, what we have proposed is that we organize a stratification system that will allow us to stratify patients into high risk, intermediate risk, and low risk, like we currently do for the ATA risk stratification. Of course, the goal of all of this is really to ultimately be able to, when someone comes across one of these patients, advise them with some better data-based, data-derived advice. This stratification system, then we went back and looked at the NCDB and the SEER, and you can see that higher risk patients shown in the solid line versus the lower and intermediate risk patients shown in the dashed line, higher risk patients are associated with a worse overall survival. The problem, as you all know, is with the NCDB and the SEER databases, it's overall survival generally, and no data about recurrence, no data about complications or anything else. And so the question is, can we do better, and how can we do better? And I think that we should be able to, through the AAS, develop prospective observational studies that ultimately can answer some of these questions. They can better inform treatment recommendations, integrate AAS physicians and their respective treating facilities, allow for more granular biochemical and structural recurrence follow-up, something that we have absolutely no data on at this point based on the studies that we have, and in the same vein, facilitate comprehensive molecular characterization. And these days, while obviously fresh tissue is critical, we can do so much just on the basis of a unstained slide or a tissue block, which could be certainly be sent to a lab or a facility that can do that molecular characterization. And so ultimately really contribute to a better understanding of these diseases like parathyroid carcinoma or like malignant struma ovarii. And finally, it provides an avenue for grant support for individuals and ultimately the AAS as well. A prospective MSO study is going to be something that's long-term. I mean, this is not something that's going to happen even to get a small number of patients over the course of a few years. But with a long-term investment in in a REDCap database, and does not have to be at the expense of the AAS. And ultimately, what would I envision? I envision that the goal of the AAS should be able to organize studies that can answer questions like these in a prospective fashion, in treatment fashion. But I don't think we're anywhere near that. I think you have to crawl before you walk, and by depending on our members, and we have so many that are, I think, interested and capable of doing these things, have the AAS provide the mechanism to have these studies approved and supported, at least on a web base. I know you've all been to the AAS website. This is something that's, you can pull down, you can get to these resources. Once you get into the member area, there's an area where you can ultimately get to studies. There are 4 studies total in that whole resource, in the whole clinical studies program. I think we can do much better in terms of getting our studies on there and collaborating as an organization to approach these rare diseases. So, prospective studies, the pros: define optimal treatment algorithms and permit members and non-members alike to contribute to research, bridge and connect our academic community and rural AAS surgeons. Some of these things, we really will depend on, I think, surgeons who are in small centers to try to enroll these patients. Further enhance the role of the AES as a leader in endocrine surgical diseases. Answer questions that we say now will never be answered because a study won't be done. I know most of you who are as old as me or even younger know that for years we used to talk about central neck dissection and whether there was a role for central neck dissection. It was always, oh, it's too big, we'll never have the follow-up, we'll never be able to do it. I think we can, as an organization, do studies like that. I wouldn't say we should start there. I think small studies driven and kind of driven by single or 1 or 2 investigators is the way to start. The cons: it requires long-term dedication and planning. I think we have that here. I think that our association is one that people will come back to, that they'll contribute over the years. The expense is something that you don't see. I don't see this as an expense for the AES. I think this is an expense for individual investigators, and hopefully with the support of the AES will allow those investigators to garner some funding, whether it's small society funding or NIH funding, to run these studies. In the 1980 presidential address to the American Surgical Society, my first chairman, Dr. Shires, noted that there were 3 established great surgical Renaissance periods. The first was when Hippocrates laid the foundation for scientific medicine. The second was an explosion of knowledge in the Middle Ages, which was really an explosion of knowledge about anatomy more than anything else. The third was in the late 19th century with the introduction of anesthesia and antisepsis. Dr. Shires proposed that there be a 4th category, a 4th great surgical Renaissance period, and that was the emergence of surgeons as surgical biologists, which at that time was, he said, over the past 3 decades, and should be truly recognized as the 4th surgical Renaissance. The surgical biologist he defined as one, to be sure, who includes those who do biologic research. Nevertheless, the surgical biologist is teaching surgery based on all of the old anatomic pathologic advances, but in addition, it is based on the physiologic and biochemical knowledge which is developed in this technologic age. Similarly, the practicing surgeon of today is truly a surgical biologist. I can't think of a specialty that this is more fitting for than endocrine surgery. And I think that as endocrine surgeons, we have incorporated molecular techniques, novel inventions and technical devices into our practice, more so than any other surgical specialty. I have to give some thanks to the many people who've enabled me to to do research over the years, to be a surgeon over the years. The first is my parents, Eleanor and Tom Fahey. My dad was a physician, a medical oncologist at Memorial Sloan Kettering, and I have to thank them for their many sacrifices they made when they were young, when I was young, to get me off the ground. The second is my colleagues at Cornell, Rasa Zarnagar, Brendan Finnerty, Irene Min there, and the third from the left is a PhD in our lab and has been driving the lab day to day for years now. Teresa Sconomilio, you can't be an endocrine surgeon without a great endocrine pathologist, and Teresa's there's no one that I ever who would ever say surpasses her. She's been an extraordinary compatriot in terms of both clinical and research endeavors. Munsu Jin, who's really driven the CAR T program, which I hope to see expand and really fill that, get to the point where we might see some therapeutic benefit. And then finally, my chair for the last 18 years, Dr. Fabrizio Michelasi, who's certainly provided his support. And then the list of the folks that have been fellows in the lab, including several who are sitting in the audience and who I'm extremely proud of all of them and have gone on to be great surgeons and surgical biologists as well. Finally, but not least, and certainly probably most important of all, my wife, Stacy, who's been my partner for 40 years, has certainly enabled me to do everything that I've been able to do. And I can't thank her enough for all that she's done for me and for our family, which is pictured here at our annual beach vacation. My kids, Caitlin, TJ, and Erin, and their significant others, Lauren, Scott, and Griffin, who have been really fabulous. So it's been a wonderful, wonderful family, and I never have too much fun when they're around. And then finally, my two little grandchildren, just absolutely nothing brings more joy than these two. And I expect that it will just get more and more as time goes on. So thank you all again for the privilege of being here. Really, I owe everything to the society and certainly to the people that I've been so privileged to work with over the last year. James, even though he was, spoofing me, for Fiemo's introduction, has been an unbelievable partner, and Alan, who I've learned so much from over the last 3 years. So thank you so much.
Tom, thank you for a fantastic talk. More importantly, thank you for some really great leadership over the past year. Whether it's been your focus on more fully embracing all of our endocrine surgery colleagues from all of the Americas, to your firm hand as we navigate national initiatives like the FPD and various quality programs. The AS has grown tremendously over the last year, so thank you so much for your leadership. I'm going to apologize in advance for the size of this. The photos on Etsy are very misleading, but on behalf of the council and all of the membership, we wanted to say thank you for your great humor, your guidance, and your vision over the last year.
Thank you so much. Thank you so much, everybody. We do now get to break and see you all soon at the Rock and Roll Hall of Fame. Peter, do you have some words? Yep.
Yeah, thank you, Dr. Fahey, for that great talk. I think you can all agree that today has been an amazing start to our meeting, and it's just the beginning. The program this year is fantastic. So we've got our President's Reception starting at 6:30 at the Rock and Roll Hall of Fame. I see the sun coming out. It's a short walk, and I think it's going to be a great time. I mean, in regards to the masking issue, obviously there's no official policy. I don't expect that we're all going to have our masks on, but we all know how to, practice social distancing and just keep each other safe. We've got a great program tomorrow. There's a SESQUIC update at 7 a.m. and then our third scientific session starts at 8 tomorrow morning. I didn't mention at the beginning of the presentations, but we are awarding best presentations for the 2 top presenters this year, and that is, unfortunately, it's limited to those people that are presenting live. We just figured that we had to keep it that way. So with that, I am all through, and we'll see you over there. There are 4 drink tickets in your badge. Use them wisely. You have to divide them up between today and tomorrow night's gala reception.